Thank you for being here. My name is Sulayman el Mathari. I'm a medical doctor and PhD candidate at the Amsterdam University Medical Center. And today I'll be presenting to you on behalf of my colleagues from the Amsterdam University Medical Center and the Aortic Valve Research Network Registry. I'll talk to you about our abstract titled Big Data Allow Further Improvement in Aortic Valve Repair Surgery. I declare no conflicts of interest. When encountering aortic regurgitation, we all agree that generally aortic valve repair is a preferred treatment over aortic valve replacement. However, there are several specific aortic valve cusp characteristics known that make valve repair challenging. These are calcified cusps, fenestrated cusps, and retracted cusps. Yet, literature on clinical outcomes of aortic valve repair in patients with these specific cusp characteristics remains limited. Therefore, we decided to study the differences in clinical outcomes of aortic valve repair in these patients. We used data from the International Multicenter Aviator database, which is nowadays known as the Aortic Valve Research Network Registry from the Heart Valve Society. And we defined three main outcome values. The first one is a switch to AVR, which is basically a perioperative switch to aortic valve replacement despite a preoperative intention for repair. Our second main outcome value is then postoperative recurrence of severe aortic regurgitation. And the third main outcome value is aortic valve-related reintervention. In our methodology, the first step was sample selection, in which we created a study group and a control group. The study group consisted of three subgroups, which were patients with cusp calcification, fenestration, and retraction. And the control group consisted of patients with normal and prolapsed cusps. We excluded patients who had prior cardiac surgery, endocarditis, vegetation, unicuspid valves, or when there was a combination of multiple cusp characteristics in one patient. Then, in the next step, we did matching based on age and gender, and this resulted in a total of 2,082 patients, which were equally divided over the two groups, and distribution among the subgroups can be seen below. When looking at the patient key characteristics, we see a mean age of 54 years old, and 84% of our study objects is male. Another interesting detail that stands out here and confirms the technical surgical complexity of these cusp characteristics is that the valve repair rate in the control group is almost 100% against a valve repair rate of nearly 82% in the study group. The next step is then to analyze the earlier mentioned outcome values. And the first one was then switch to aortic valve replacement. 90% of all patients had a preoperative intention to repair. And in 3.6% of the cases, surgeons perioperative switched to valve replacement. If we look at how this translates for each cusp rate, we see a significant increased risk for all studied cusps for switch to AVR. This effect was strongest for patients with cusp retraction, followed by calcification and fenestration. The second main outcome value was postoperative recurrence of severe aortic regurgitation. Here, we studied the odds to develop a grade 4 aortic regurgitation compared to grade 0 or grade 1. We had a median follow-up time of 1.1 years, and our results, shown here in this figure, demonstrate a significant increased risk for recurrence of postoperative aortic regurgitation, severe aortic regurgitation in patients with cusp calcification and cusp retraction. This effect was not seen in patients with fenestrations. The last main outcome value then is aortic valve-related reintervention. 2.4% of all patients that underwent aortic valve repair also underwent a reintervention within a mean follow-up time of 2 years. In the table below, we can see how the events were distributed among the groups. 17 reinterventions belonged to the control group, and the rest was approximately equally divided among the study group. For statistical analysis, we performed a Cox regression analysis, which you see here. And there is immediately one outlier noticeable, which is the red line, representing patients with cusp retraction, showing an increased risk for reintervention after 1 year as well as after 2 years. In patients with cusp calcification and fenestration, there was no difference in re-intervention compared to the control group. Then I would like to end by sharing the key points of the study as take-home messages. Firstly, we observed that the perioperative switch to aortic valve replacement is apparently more common in patients with cusp fenestration, calcification, and retraction compared to patients with normal cusps. And this implies that the perioperative assessment in these patients plays an important role in the final choice of treatment. The second take-home message that I want to share is that patients with aortic valve cusp retraction or calcification still undergo, maybe too often, aortic valve repair procedures which result in early re-intervention or recurrence of severe aortic regurgitation. This suggests that aortic valve repair in these specific patient groups should be performed with caution. Then another interesting result of this study is that patients with aortic valve cusp fenestration did not seem to have an increased risk for re-intervention or recurrence of severe aortic regurgitation, despite having a significant increase for switch to AVR perioperative. This implies that surgeons are well able to distinguish appropriately feasibility for aortic valve repair or aortic valve replacement when encountering cusp fenestrations. And then the last take-home message that I want to share, and it's maybe the most important one, is that big data is allowing us to improve surgical outcomes by better and better analyzing which treatment is the best for which patient subgroup. Today I'm pronouncing this message here on behalf of aortic valve repair feasibility, but of course I believe that this message is broader applicable in our field. That was it. Thank you for your attention, and I would be happy to receive your questions.